Case number 3 is a 65-year-old male, known case of type 2 diabetes with class 2 angina, CT coronary calcium score of 958 with a fair LV function. Angio revealed heavily calcified lesion in mid-LAD. Syntax score is 10. Today's plan is PCI to LAD using Rota and or IVL under OCT guidance. Coming to the angio films, this is the RCA with insignificant lesions in proximal and distal segments. And we are going to work through this tortuous loop and accessing through the right radial. This is the calcified LAD. Over to the cath lab.
Hello.
Dr. Patel, you're on.
Yeah, lovely. So, am I audible?
Yes, Tejas. We can hear
So, what do you think?
you. It looks very unfriendly.
Unfriendly. What looks unfriendly, the lesion or the loop?
I think everything.
Everything. So, we try to make it friendly. No problem. Huh? Let us see. So, I am going ahead with the same set of thing like 6 French EBU guide, 5 French long catheter, Professor Mir Jamaluddin and Professor Akasaka, please, yeah. And I will cross that loop with this baby J only, baby J wire from Tarumo, which is my favorite wire. See, yeah.
Thank you, Dr. Patel. Here, first challenge is the loop. And
Yeah.
for the younger colleague, you will have to show the how you do over this loop.
Yeah.
Oh,
See,
straight
the
away.
catheter is friendly.
Yes.
Everything is friendly. The guest faculty is friendly, and even the participants are friendly.
And,
Very
and
true.
our
Very nice.
performer is also our friendly.
okay.
Yeah, yes. So we had challenge. See, the point what I want to prove is we had challenge with that diagnostic catheter 5 French. But then you could have seen the views. I have taken EBU at that point of time 5 French EBU to cannulate it properly. And I could realize that the loop disappears
Yes.
with the EBU. And now you show there is no loop there. Just show.
Go up.
So,
Just above.
upper,
Upper. And
There is
while
no-
pulling it back, we will show that there is a 360-degree
Loop.
or subclavian loop there. Because simply the muscle of guiding catheter has helped me to overcome. So, the point which I want to prove here is you should not be afraid, of working through the right radial. If you encounter this loop, you should put a guide catheter. 90% of the time, the problem is solved immediately. And sometimes, if you are going through the loop and hooking the artery like this with this catheter gives additional extra backup in form of the subclavian loop. And it will not move even if the lesion is very resistant. Okay, go to epicranial. भाई आना आ बाजू ले ले. Yes. Okay. We'll take a couple of views there.
Heavily calcified.
This is a genuinely heavy calcium.
Heavily calcified.
A bad lesion where I will not think of doing
Curvature.
IVL without Rota and balloon, you may be with balloon dilatation.
Maybe curvature.
And there is a curvature also. Go to areocranial.
For the wire, Tejas, are you going to go with Rota wire, a front or a micro catheter?
I think this is the case. Despite my experience doing so many Rota, I will use micro catheter and the sleep extra floppy run through wire.
Run through with micro.
Give me fine cross and run through.
Besides that, those who are younger, those who have just started or will start, they will have to know that it is wise to have to cross the Rota wire with an microcatheter.
Because Rota wire is an uncoated stainless
Yes.
steel wire and you don't get a good torque.
It almost looks like a functional occlusion type.
Yeah, that's right.
The flow is down.
Yeah. This wire, there is a small chance that this wire may not go, but let me see.
Needle can be. Needle. बस needle आप पंचर.
Is there any difference in the strategy? Any of the panelists or?
No, everybody is agreeing with your strategy. The only other option brought up was to use a better wire than just a run through, given the disease and the tightness of the lesion.
Is there any preference for the microcatheter, whether it's a fine cross or caraval?
In our lab, the workhorse microcatheter is fine cross.
Is there any advantage over caraval or something which is more torqueable?
No, because we are used to. I have not used caraval as a upfront as a microcatheter in my lab. So the most important thing is you should have the feel of the character of the hardware, and whatever you are comfortable with, you should be using that. Give a AP caudal view. Okay. निकल ही दूंगा. I am just simply trying to push. Oh, no. Yeah. There is an angle there, and it has a tendency to go in diagonal. Sanjay, I think we need to give a little. I like,
Epicranial?
Let me see, it won't go otherwise. You have to give it secondary and tertiary curve, I suppose. Any suggestion?
If you pull the guide,
go to LAO caudal.
Yes, LAO caudal view can
I am trying to play with my guide catheter tip also. Yeah. Just see now.
Yes.
I will pull it back a little bit. You need to give a curve, I think.
I think it will go.
See?
It will go.
Yeah.
No, scout. See?
Okay.
It has a tendency to go there only.
We can go.
Okay, go to epicranial. There is a small chance, I told, but I was reasonably confident it should go.
Microcatheter.
Yeah, of the wire.
What burr are you going to start with?
This is 1.5.
1.25.
This will be 1.5.
You should do a lot of ablation because there is a step in there.
Yeah, that's right. See here, I am finding resistance. Here I am finding epicaudal.
John actually predicted that 5 minutes ago.
Yeah. So guide catheter, I will make it little more coaxial, and I will be very patient pushing it, and I will be giving constant pressure. And here, if it doesn't work, keeping microcatheter there, I will be using Rota wire.
Yes.
Yeah, because
Yes.
I am simply trying to maneuver the guide, the microcatheter, rotate it. It's not moving. No problem. Go to epicranial.
Can you talk the front course?
Scout.
I think I saw you turn a lot of the front cross.
Yeah.
So this microcatheter, you can talk?
It has gone?
Yes.
No.
Yeah, just across.
It has gone in scout.
Crossed.
No, it has not crossed, doctor. It's
No.
almost there. But
Almost there.
this is the site where I may need,
I think if you just put a rota wire now, it should work.
yeah,
Yes.
scout.
You put the
I
rotor
think
wire
so.
in now, it might cross.
I
Sometimes,
think we take a rota wire
Or
now.
we
Yes,
want
sir.
to direct with 1.5?
sometimes whenever we
Let us see
can't
what
cross this microcatheter, then we keep here and cross the.
There is another possibility. I think Sanjay suggested we can try to dilate it with 1.5 or 1.25 balloon.
Yeah.
But we
That's
can
true.
go in with rota wire. Let me try.
Yes.
જોઈ લે છે ને ત્યાં આગળ બરાબર.
ઓકે પુશ કરો.
Rotor
ખેંચેત કરાર
wire
જશે
will go hopefully.
પુશ કરજો તો હું ખેંચું છું. ઓકે
Okay.
ટેક રોટા વાયર.
And see, Sanjay will be, I think, giving only the primary curve for this, nothing else. Very, very modest primary curve. Has microcatheter come out little bit or is the same? Let us see. Let's go. Guide catheter is unstable, huh,
I
Sanjay?
think it is good in Valin.
Okay.
Torque. Okay. Stop.
How much are we going to struggle? Go to epicaudal. I think the guide catheter is not right because I get a resistance there.
Yes.
Oh,
A little pull on guide.
Gentle.
little pull.
Gentle pullback, yes.
Yes. Fine.
Uh,
Yeah, the microcatheter is bent at the tip of the LID.
Hmm. Epicranial.
Wait a minute.
Okay.
Can you using
Go to
talker?
epicranial.
You're through now, yeah, you're through. You're good.
Dr. Patel, do you use a talker or just a hand?
This is hand. Yeah. Somehow this wire, I get a good tactile feel only with my hands. It's an individual preference, I suppose. Looks good, na?
Yeah.
Yes.
Little more.
The tip is the key here, the small tip, very important.
Here, if you are giving a secondary curve, you are in trouble.
Yes. It'll trap everywhere.
Yeah. It's okay, Sanjay.
Okay.
Yes.
Now, before removing, I go to epicaudal, make sure that my guide catheter tip is fine and guide catheter is not in a good position. You saw that? So I will adjust it.
Okay.
These are very small but very important steps.
Yeah, agree.
Well, we'll have
So
to
you
use
need
the
to
trapping.
keep the wide.
No, it's excellent.
Franny.
Excellent.
You don't want to
We have
clean
not
the
excellent.
rotor
Excellent.
wire. at
Yeah, this is
moment.
excellent, right. Sorry, I thought it is a guide wire.
For the younger colleagues, to start rota, we must have to engage the guide very nicely.
Okay, Sanjay.
Rota 1.25.
I was thinking of taking 1.5. Sanjay wants 1.25. What is the consensus?
I think either one will be working. If we're worried about the burr trapping, this is the lesion
Yes,
I would
yes.
worry
Yes.
because there is a
Yes.
step in it.
Yes.
So 1.25, right?
One
Yes,
five.
I also.
1.5.
I think
Like 1.25.
1.5, 1.5.
1.5, less likely to get
Okay,
trapped.
let's inject and see in this view.
We can step up.
Okay, we'll go with 1.5. We'll be slow. Let's go
This
in.
one, when you trap, is a big problem. Dr. Patel, so
Yes.
there's a no rotor glide in India, right? The rotor glide. So what kind of solution is prepared in the?
No, we
rotor
don't
flush?
use, we don't use that,
And we don't have.
and we don't have it.
So
Yes.
what you do
Have
in the
Patel?
solution?
You have prepared by your
Can
own.
you go over
formula.
the regimen again?
Acha, for what?
The rotor flush.
Flush. Flush is a 500 ml of normal saline, which has 5,000 unit of heparin,
Heparin.
500 microgram nitroglycerin, and 5 milligram everything 5 milligram diltiazem.
Yes.
Yeah. Dyna on, check it. Okay, Dyna off. 150,000. Okay, Dyna on. Do you anticipate any problem entering the LAD?
I think the very proximal LAD is diseased. and
That's
so
what I feel.
You might have to start spinning in the left main.
Exactly.
We were talking about it, and half of us thought the imaging will decide, but I think
Imaging, you can't
Yes.
image this area.
Yes.
afterwards. But I think it's going to be decided right now. The burr will decide.
You can't image. Nothing will go in.
Yes.
Are you Dynaglide in or just no Dynaglide, right? At this
No,
moment?
only while pulling, I am using Dynaglide, not by pushing. Now it may jump. If it doesn't, then I may use it. I will try. Like this is good.
That was-
This looks good.
That was nicer than expected.
Yes.
Yeah, that's fine. We'll simply see one view. Sorry. Inject. Looks good?
Yeah, perfect.
Chalo. Epicranial. Okay.
Do you decrease the tension first?
Yeah, I would take off the torque, yep.
Guide catheter is too deep in this view. Huh?
Yeah.
It looks good. Okay, no problem. Dyna off. I am going very slow. Very slow, buddy. Wait for some time. Record. કર્યું? This is all fluoro recording. I think we might need to increase the speed, right?
No, I think it
It'll go through. It might take a few more passes, but
few more passes don't.
Okay,
You don't need
because it's not dropping significantly, right?
Yeah.
Yeah. How much you wait in between? Again, people have different strategy. Samir, Tak and John, what is your strategy? How much you wait in between the two passes?
a few seconds really. I mean, we think we wait longer, but if you have the timer on, it's not very long. So all of us have severe ADHD.
Any hemodynamic change, any EKG change at that time?
Yeah. No.
Yeah.
See, it's not going in.
Yeah, it's going to take a
You
few
will.
passes. Yep.
Will you like to increase it at this point or not?
I would not even increase the RPM. I just do more attempts.
Yeah, not at this moment.
We will increase by 5,000 or maybe 7,000.
Sure,
Let's
no,
say.
it wouldn't hurt. Yeah. I think the key is the duration of the run.
See, it's too resistant.
Yeah, there is a lot of plaque there and not geometrically friendly.
I anticipated this problem in this case.
Absolutely. It is going to cut a lot of lumen, which is a good thing. It's going to be bigger than 1.5 when you're done.
See, the problem sometimes is, any new cardiologist who wants to involve with all these devices, they feel that you have a lithotripsy balloon and we can straight away push and do it. No, this won't work. Lithotripsy balloon simply will not go in.
That is true.
So, Rota is one procedure which has survived since last almost 30 years, right?
That is true.
Yeah. Although the uptake has not increased, but it has survived for a very, very long time.
1993. Yep.
Yeah. जा अब जा This is making me nervous.
I think it'll take more passes.
But you anticipate that.
Sanjay says that you take 1.25 and go at a very high burr. What is the opinion, or what do you feel?
I think it'll take you another 7 to 8 passes before it'll cross.
Go to 180 now. No problem.
So
Increasing the frequency.
1,80,000, yes. I think it is moving little bit.
Yeah, it'll take a few more passes.
Okay, wait for some time. I don't know why the patient is so stable.
that's a good part.
See, they don't have ADHD, that's why they will benefit.
But you show a very good technique. You see the guy is a very good support,
Yes, it'll take a few passes.
and you tap it. It's no rush.
It's making progress actually, little by little progress.
Do you flush with the contrast in between, or you don't do that now?
Injection.
It will not so much.
I don't think it will be helpful, but let us see.
Yeah. It was the original recommendation.
Some
when
slow
it
flow
started,
now,
yeah.
right?
Yeah.
Yeah, let's see.
Correct.
Chal.
But I think the flow was down even from the beginning, so it'll be okay.
It's moving.
Yeah, it is going a little by little. It's going to take another 3 or 4 passes. There we go. I'm happy to be wrong.
So 1,80,000, Dr. Akasaka, it is a Japanese, yeah.
We usually do 150.
I have learned rotational atherectomy from Professor Samin Sharma way back in 95, and he will be very unhappy seeing me, going for 1,80,000, because he taught us one more pass, yeah, quick. Now there is hypotension.
Polishing run.
Okay, I think we are done. Dynaglide on, and quickly we come out.
There might be some no reflow. Are there any ST changes?
No.
Oh, good.
No,
Okay,
I
so-
can see a good normal T wave.
Hypotension.
Hypotension is there. We give fluid and some.
injection में
pressure
जो
below.
पहला-
Yeah, just no. We must confirm there is no perforation.
Yes.
No. It looks
Atherectomy.
good. Go to epicaudal.
Atherectomy.
First
Back.
thing I will do is to adjust my guide catheter, because I don't want to dissect the left main.
Yep.
Scout. Guide catheter જોઈ લે તો.
1 મીટર 0 બરાબર છે ને?
Zero જુઓ તો.
0 કર
Zero kar. Just make a proper zero. Quick. Wait. બરાબર છો ને તમે? કઈ વાંધો નહીં. Relax.
0 કર. Okay, 0 done. Okay. બસ. So, little
See,
bit
there
of-
is hypotension, but the ECG is pretty
Atherectomy.
normal. Give
Atherectomy.
Atherectomy.
Yeah, it's vasodilatation
fluid.
probably. Just vasodilatation.
You give any medication for the blood pressure?
Adrenaline given intravenous. You know what? For vasovagal or this type of hypotension happening in the cath lab, we feel that it is a cardio inhibitory response, and most of the time people give atropine. But I always feel that in the cath lab it is vasodepressor response and adrenaline works more than atropine. I want to know what you guys are doing.
Yeah, I think this might just be pure vasodilatation from the drugs. So adrenaline might work very well.
It looks good now.
Pressure is going up.
Good.
The problem,
And ECG is not.
Relax.
there we go.
Adrenaline ni garmi hai.
Yeah.
So the pressure is normal, ECG is normal. Sanjay, we take a view.
Yes. Amal epicranial.
You just see this. Sure. I think left main and LAD initial part looks good as it is.
Yes,
Go
it
to
is.
epicranial. There is a good flow, much better flow than before, I suppose. Let
That
me
is
see.
true. That is true. I think that was just all drug-induced vasodilatation.
Wow, it's fine.
It's a
So,
big variety.
what should be the strategy now?
Imaging could be, it always
Image,
helps.
the OCT will not go in,
Right.
and IOS is not going to be helpful in this
I
situation.
think I would do IVL now.
IVL also will not go, Samir. I can try, but I will dilate this with a
Without-
non-compliant balloon
Yeah,
first.
true, absolutely.
Then I will put a,
Micro.
I think eventually IVL before stent. And then prior to that, whatever it takes
what
to
we
get it
do
done.
is we have to now change over
Micro.
to the wire, micro catheter.
Sir, is there any condition where you would go upfront 1.8, like 1,80,000 versus 1,50,000?
Never, no, you start with 140, if you are a beginner, you start with 140, not even 150. And then, 150 is our default start, but very rarely we go above 160. In this type of situation only I will think, because it's not going to work otherwise.
So we make our fellows hold the burr in their finger and activate it and see how long they can hold it. That's how they know how long to stay on the pedal.
So the burring speeds, like the lower burring speeds, there would be more of a wobble effect when the burr speeds are low, and therefore the luminal gain would be much more in the lower burring speed is one of the thoughts.
I
think with rotablator there is less of that mechanism. With CSI, that is the main mechanism.
Yes,
Ambulance.
yes.
So would you wire diagonal now?
IVL.
First diagonal?
Pardon?
Diagonal?
No. When I focus a major territory in this complex situation, again I am selectively blind.
Yes.
And I don't want too much of crowding inside the coronary.
So to the previous point, the lateral displacement of rotablator burr, if you do it in a test tube outside, is actually higher as the speed goes up. It's counter. We have done that in a bench test.
Now, Sanjay will show you something. This is a regular wire. My wire has gone inside the microcatheter, so we will trap it, trap this wire with the balloon, and then we will pull it out. Get me a 2 millimeter balloon.
2.5. 2.5.
You read 2 millimeter law.
2.5. sir.
2.5 is fine, no problem. Which is that balloon? કયું છે? અચ્છા, NC emerge, no.
That is
Chloric,
6 pence.
it's okay. Fine. કઈ નહીં, it's okay.
જાય છે ને smoothly. Okay.
For 6 pence guide, we usually use 2 balloon for trapping.
Yeah. Okay.
Okay.
Sanjay, what atmosphere you will go?
8.
8.
Six.
Okay. Sanjay has
Eight,
inflated
10,
at
even
8.
10.
And now he is removing the fine cross, you can see.
It's okay.
Fine. We are out. He is deflating. We are removing this balloon. Okay. Out. All right.
Okay, આજ balloon થી direct કરना છે.
This balloon we will use 2.5.
May not go.
What do you think? Will it go? I tell you, I have a presumption it should go
Yeah.
The way my microcatheter went in,
Yes.
I am very confident that it will go.
It will go.
We
It
have
might
done, we
fight
have
it.
done a very adequate burring there.
Only thing it is inflated.
2.5, 15.
Yeah, it is inflated, Sanjay. You know, there is a point. We don't want that.
Yes.
Yeah, get me 2 point. Which one you have? Get me 2 by 15 or 2.5 by 15 NC emerge. But after proper dilatation with non-compliant balloon, we are going to take one OCT run, right, Dr. Akasaka? And then I will do IVL,
Or not.
and then we will see another OCT run. What difference does it make? And then at a final, so 3 OCT runs we are taking.
You don't want to do OCT now?
No, no.
Pre-dilatation. First pre-dilatation.
We
then-
don't see anything. We will see only calcium and no significant, thing.
Even
Because-
contrast will not go inside.
See, I tell you, what I see, what my understanding of calcium management is, that with non-compliant balloon, it gives big blocks and of cracks. With rotational atherectomy, you will see some churning at the wall of the artery. You will realize that rotational atherectomy has been done. And with IVL, it is pulverization, and sometimes you don't see anything and you see a little better lumen. This, without balloon dilatation. But don't you guys realize that without this imaging, how much disservice we have done to our patients in past?
That is true.
They will survive though.
Little back.
Yeah. Oh, we did the best we could anyway, right?
Okay, fine.
Okay.
I have one question to Dr. Patel. In this type of scenario, very tightly and
Record
heavily
and-
calcified, should we go from smaller but to higher, or as you have started 1.5 is the beginning?
Yeah, for a beginner with this type of calcium, I will prefer 1.25.
Yes, that's
And 1.5 I took because we have done many such cases and we have got away with that in this situation with our experience. That's the only reason.
yes.
But if you go as per the book, you have to take from small to high.
Small to high.
It adds to the cost, but then it makes the thing safe.
Yes.
Inflated already.
પાછો લઉં ને એપી કોડલમાં જાઓ તો હવે જોઈ લઈએ સ્કાઉટ જો ગાઈડ કેથેટર ઇઝ વલ્નરેબલ I don't like it. Yeah, scout. Yeah, this is good.
Good morning, Patel sir. Ms. Jamal sir.
Yes.
Me, Dr. Amol.
Professor Amal.
I have 3 questions.
Fine.
Yeah.
Number 1, whether after balloon dilatation,
15,
after
16,
imaging,
20.
what are the factor will depend? So whether we will use IVL
Still.
or direct
It's
stenting.
okay. We'll go with IVL.
Okay, 20.
Because IVL is rare, it is not available in most of the situations.
What atmosphere?
In,
22.
in
22.
Bangladesh.
Okay.
After pre-dilatation,
just
he will
inject and
see
see.
the imaging,
Imaging.
and after imaging, we will decide whether IVL will be necessary or not to see the
Fine. Looks good.
calcification, whether the calcification is deeper
So,
and
to save some time,
extension
we
of
do
the
IVL
calcification, diameter of the calcification.
IVL
Everything
2.5.
will depend on this, whether IVL will use or not. And here, from the scenario, it looks like that IVL will be necessary. And that is why Dr. Patel is thinking for IVL. first.
IVL is necessary to
Necessary,
achieve
yes.
much better minimum
Lumen.
stent area.
Yes,
That's
yeah.
right.
Yes.
Without IVL, can we use only Rota in this case?
Yeah, if you don't have IVL, you can use Rota and stent.
exactly.
But
Yes.
you know what the literature says? Again, Dr. Akasaka's seminal work. Minimal stent area. It has an impact. If it has to be at least 4.5 or 5.
Burr.
If it is less than that, it has a significant impact on TLR,
Yes.
and MES,
Yes,
right?
stenosis and MES.
Yeah, restenosis and MES. 7 and 17% difference, significant difference, yeah. 14 and 41% in MES.
For that reason, we want IVL.
Okay. Fine. The contrast. Contrast.
There is a way of preparing even this catheter. Sanjay is doing it
Negative.
stepwise.
Negative.
Yeah.
That is vacuum. Release.
भाई
Release.
ત્યાં આગળ લગાડી દો.
એક મિનિટ ફરી એક વાર. Release. Okay. ફરી એક વાર કરીશું.
He is taking time. He is trying to remove the air.
You don't want to put a stopcock there, Sanjay?
Yes?
Stopcock. Tak is asking that you don't want stopcock.
No. This is good. Okay.
He's answering
Okay,
like
fine.
Dr. Saito. No.
Everybody was thinking that, I think.
Yeah.
Sir, IVL versus cutting balloon post-rota.
Cutting balloon is also good, but here I want to pulverize the calcium. Cutting balloon will give cracks to the calcium. IVL is going to pulverize it because such a huge calcium block, it is, to get a good minimal stent area, I feel, personally, this is my opinion, personal opinion, that pulverizing calcium will make sense.
I think before IVL, we used to use the cutting balloon all the time.
Epicranial.
Easily crossed.
Yeah.
That is what I am asking. The
Yeah.
results were
Scout.
Results were, I think they were less,
IVS versus cutting balloon.
Little.
yeah, I think they were definitely less ideal than IVL. IVL
We are expecting a better minimal stent area with IVL.
Absolutely, yeah. Especially in circumferential calcium.
It seems to be deep calcium as well, wherein cutting balloon won't be of so much use than an IVL. IVL would be better in case of a deeper calcium which is there.
With circumferential, calcium,
balloon is
IVL
also
works.
well
If you had done imaging prior, what degree of calcium would you prefer IVL? More than 180, 270?
More than 270 usually.
270?
Maybe Dr. Akasaka can answer that from there. The question is, at what degree of calcium arc will IVL be clearly better than the cutting balloon?
I think at the moment the data shows 200, more than 270, right?
Yeah. 6.
I think the most common mistake we make is we use IVL in fibrotic lesions. And it doesn't work and we call it failure.
And it is not expected to work.
Exactly. I think that's where imaging helps a lot, distinguishing fibrotic from heavy calcified circumferential lesions.
Deflate.
And cutting balloon works marvelously in those fibrotic lesions.
Exactly.
And you cannot quantify fibrotic lesions as vis-a-vis like calcific lesions, as you don't know how they would behave.
That is true.
Guiding is being sucked. Yeah. Go to epicaudal because I have to have a control over my guide catheter. Wait.
Is the IVL balloon not moving back?
Yes.
Yeah, that has been a little issue with real
Came
calcium.
back?
Yes, little.
We can give here. We have enough pulses. Give. See, if it doesn't come back, Samir, give 10 the pulses, or maybe 20 or 20 pulses should be fine.
In the same location, yeah.
Because it means it is trapping there in calcium.
Yeah, I think also coming to zero is helpful instead of negative.
36. Away 8 kar jayega. I think go, I try to pull it. If it doesn't come, we'll go here
No,
again.
it will come out.
It has come out, right?
Yes.
Yeah, go.
It has come after second inflation in the, it has come after second inflation in the same
One
cell.
thing is sure that I am going to use all 80 pulses in this case because, yeah.
That's right.
Yeah, go to 6, 8 Sudhija.
8.
Up to 8 atmosphere.
Okay,
Yeah.
Better second.
Your pressure is also increased up to 8.
Now just give a little short injection. I want to see the situation in the left main and ostial LAD.
Okay. Fine.
The audience must be thinking that why I am so much worried about ostial
Yes.
LAD and circ. But by doing this, sometimes inadvertently you lift the ostial LAD.
Right.
Absolutely. It is diseased all the way to the ostium. isn't it?
From ostium.
Yeah. Come back.
Yeah, you got it.
See?
Still, 1 second.
Yeah.
Yes.
It came back little.
Yeah. Jao. We have enough pulses still. Jo.
One more question is the sizing of the IVL balloon. So many a times it's the taper of
1:1.
the arteries. You have a real step down. So how would you size? Would you go 1:1 for the proximal or for the distal? Many a times more than one artery is involved. So that also becomes an issue.
So you have to go with distal, but then if there is a 0.5 or bigger difference, we take a second balloon.
That becomes very
And
costly.
yeah.
That's the issue.
And with the distal dia, 1:1 we usually choose.
See, I am pushing my balloon in first before I am engaging my guy.
Yes, over the balloon you are engaging.
Yes.
You have
Yes,
taught it
scout.
previously also.
Yes.
Yeah, go here.
Hmm.
Now my question to you guys is, should I lithotripsy the ostium or not?
I think this balloon might be undersized for that anyway, even if you wanted to do it, right?
See, it's a diseased one, so at least the diseased part, there will be some effect.
There might be some effect, yeah.
Yeah.
I would,
You might not necessarily do that.
my bias is to stent all the way
Inject.
into the distal
I think
left
we have
main.
already done it. I think so.
I think so, yeah.
No, we have
No.
not done.
I would treat
we
that
leave
whole
it.
area.
Ostium is
I would treat that all the way to
Spared.
the left main.
I think so.
Yep.
Because the rest of the things are very small distally. Come out.
Now, only the
It is
fear
so?
is if it dissect into the left main,
Okay,
the circ is
fine.
not protected right
I'm
now.
giving here.
But circ, we can wire it, and it is RCA is a quite big. He has quite big right, and I want least chances of restenosis in the left system. And so that's why I will be more concerned about that.
Now you're going to stand all the way to the distal left
It's okay,
main.
Sanjay.
yes, as
Make
because we
a
have
pulse for calcium now.
dilated from the ostium.
Chalo, go to epicranial.
আমার দেখা তো
Last,
কোনো ছেলে তোটেলো
last 10 pulses, Sanjay says that the most heavily calcified area we give. So I think so. It is here,
yes
right? Go.
fine. So
What kind of atmospheres are you using?
6 and then 8.
6 and 8.
4, then 6, and then 8.
Now, do you dilute the dye more for IVL or just go regular?
That Sanjay can tell
regular
you.
60 by 40%.
60-40. Okay.
60-40.
Because there are some people who believe that the more dilute, the better the transmission of the pressure wave.
Now, what is the strategy which makes you think use 1 or 2 stents? If my IVL balloon goes simply in and out, then there is no problem.
Yeah.
I think one stent is good.
No problem, no
Hey,
problem.
guiding up.
Go to epicaudal. Whenever I want to cannulate, I make sure that I don't cannulate in the cranial view. Scout.
Yes.
I think we well tolerated.
Okay,
Yeah, that's
fine.
it.
All right.
Okay, now we take an OCT run.
Yes.
What's the longest stent we have in India?
48.
48.
At least I know of.
Is that Zions?
Yes,
There are 3 companies. One is
Expedition.
Abbott, Zions, Expedition. then Boston Scientific, Synergy, and the third one is SMT. They make cruise also in 48 length. Yeah.
Cruise that you use.
Yeah, yeah. It's a very trackable stent. Go to epicranial, very trackable. Probably the most trackable stent.
I have not used. I do not know about it, but it is in our country.
Yeah.
Okay, take a second.
Now, chalo, let us use.
I've seen biometric used overseas, but we don't have it.
Oh, just maru mic sarkhu karo. Dur. Bas. Chalo. Now, okay? Little more?
Okay, I think it's
I think
okay.
this is
Okay,
okay.
okay,
Just
okay.
take a scout. And we will take a survey mode. Huh? Okay, survey mode.
You want to see a left main too?
No, go to epicaudal. Let me see. It will be partly little bit of left main. Ostium, LAD ostium and partly, yeah.
It's okay.
Yeah, this is
Yeah,
okay.
that's good. That'll show.
That's all right. Yeah, go. खसेड़ी लाई थी. Go inject.
I give you.
Calcium, always delayed injection, regular and a long lesion, a very quick injection. This is what strategy we have.
Mike, yes.
It's a nice study.
Now, Professor Akasaka in action, he will discuss.
Right. So let's start the distal portion right here. Only as a mixed plug, eccentric, small amount, right? And then, yeah, moving slowly, yeah, here, right, might be calcium, some small dissection, the distal side, we can identify very eccentric calcium here, and yes, almost circular calcium here, and we identify the dissection here, a crack, some cracks here, and very eccentric plug. The opposite side might be the mixed plug with calcium, right? And almost more than 270 degree or circular calcium here, and we can identify small crack, lots of small crack, right?
And pretty superficial calcium too.
Yeah, and here is yes, just proximal, right? And CX.
Yeah,
and left main. Left main is very normal, right?
Yes.
Completely normal, right? I'm afraid small damage here, but I'm okay.
Probably, but it's okay.
Might be okay, yes. And then I try to change the site, right, a little bit. Again, I always put 8 o'clock, right? Because I already explained the upper side is epicardial side and the lower side is myocardial side. Then goes right again, yes. Here is a blood, not a plug.
It's a blood or clot? It's not blood clot, eh?
Some crack.
Yeah, there's a blood clot.
Yeah, we can identify the yes, crack.
But somehow the landing zones all the way, the proximal landing zone looks very clean. I don't know why. See?
Distal landing zone.
Proximal and distal both.
Yes.
Proximal landing zone.
Proximal landing zone. Here is at the bifurcation.
Yeah,
right?
and just after bifurcation, if you see.
Yeah, here it's very nice.
No, at the LAD, just after the left main,
Just
LAD
after-
ostium.
yeah, LAD, okay, right. Here might
This
be
is good.
yeah.
So
Some
this-
deep calcium here, an eccentric plug. And the other side is completely normal, right?
Okay. So my question to you guys is, should we include left main and stent LMCA to LAD,
We have
or we can
another
spare
branch,
it?
just distal to the CX. We can identify some branch. I'm sure.
There is a middle branch a little bit.
Yeah. So
I think I would go to left main because you will get good expansion.
I think so.
Ability.
So I will use two stent strategy here.
right.
Distally I will use 2.5 and proximally 3.5, and then I may post dilate with 4 or 4.5. Yes. We can take onyx here, Sanjay. We'll take onyx.
So wait a moment. And try to measure the length. Much distal. Total length is might be nearly. You want to put it here? Much distal.
You can go distally.
Sorry, this. Yeah, we can identify the septal branch.
Yeah.
The distal portion, right?
Yeah.
But still some very thick fibrolipidic portion,
Yeah.
right?
But not a bad landing zone, right?
Not
Dr.
about,
Akasaka, yeah.
Yes. It might be okay. Yeah, right.
Yeah.
Here, right. Okay. So total length is 54. From the
Total length is 54.
54.
For this type of lesion, sir, I have one question. That there is a diagonal, so we should not overlap the stent over the diagonal. We should keep the distal stent.
Then there is a problem, I tell you. Then there is a good chance that you dissect in the segment between the distal segment of the proximal stent and proximal segment of the distal, because it's a small area and proximally I need a big stent. Let us see if at all, I may go to epicranial, because what I keep in mind is how much revascularization I do, and that I count that how much I have compromised versus how much I have given. Yes. Sanjay, we should cover the diagonal in that case. What do you think?
No, we should.
Yeah.
We should cover.
And distal landing zone in the most cleanest of the area we will give.
Yes.
So in that case we can use a 2.5 by 34 or 38 to start with. 2.5 by maybe 38. Get me onyx.
You're going to protect the ramus?
I will see, just a moment, go to epicaudal. I will see the ostium of ramus and then I will decide to wire or not to wire. The ostium is so big and clean that it can't occlude, so no problem.
Ostium is good.
Go.
From the OCT, can we see the ostium or the ramus?
Mike.
Yeah, that is
Yes,
seen there.
can you see the left main, right?
Yeah.
Slowly, yeah, here is a CX, right? At
Yeah.
8 o'clock. And you can identify the orifice of ramus is a little bit different here, right?
Actually, the bigger one is ramus and the smaller one is LCX. Yes.
This is ramus. And little bit proximal side, we can identify the LCX, right?
Yeah.
Bigger one.
So this looks good.
Good.
Nicely seen also. Very nice demonstration.
So if that looks okay, I mean, what criteria you use, you don't need to protection. You don't need to put a wire protection.
We have to pay attention to the disease and the size of the orifice. This is an LCX. You can identify, right?
Go to epicranial.
Very similar to the left main size, right? And also you can. The position of the ramus is not directly coming from left main or LAD. This comes from LCX mainly, right? No, here is an LAD. I'm sorry. Yeah.
See
the
way the stent went in. So I think we have done a good calcium management here. Should I pull it back?
Yes, little back.
Yeah, I think you come back about 2-3 millimeters at least.
Just see now.
Maybe
Still
even more back.
Yes,
yeah.
yes. This looks
This looks good. Just check it.
looks okay.
Or little back.
Little back.
Little
maybe
back.
1 or 2
Little back. Yeah,
millimeters.
there is a plaque there.
Yes, 2 millimeters back, right there.
Just see now.
Fine.
This looks good.
I think maybe that's good. I
That
think.
looks good. Go.
Yeah.
12.
Okay, again, I have to comment the protection of the lemurs, right? You can identify the huge orifice and no disease at the orifice, right? Yeah, we can speculate from the LED side.
Yes.
But, if you want, you try to pull back from the lemurs, but it takes lots of contrast. I think this might be enough, right?
Yeah, it will. My simple thinking is, if you have a normal ostium of a big artery, it doesn't occlude. Go.
You have pulled back slightly and going up.
Yeah. Now go to, you can go to 20.
It is your regular practice.
20.
Fine.
Look here, this balloon expands. And I am removing this. In any case, we need to take the size.
Okay.
For size, let us see one view and then we go to epicaudal. This looks phenomenal. Go to epicaudal.
Oh. Chalo.
Let's check it.
Seen it?
I will take one more injection here. Maybe
20.
we can go with 4 by 18.
18 is
Yes,
good, yeah.
yes.
4 by 18 at a reasonable 8 or 10 pressure. Then we pull back. If need be, we will work inside, right?
Yep. You might have to do part at the left.
Yeah, I think so. 4 by 18. Get me onyx.
Dr. Kwan thinks we should go longer, 23.
Yeah, because your balloon, the shortest one is at 8 millimeter, right? So if you put a part at least 8 millimeter will be the left main. So I think 23 may be better.
Yes, at
I think.
22.
22?
22. That,
Okay.
that's because you have to keep 8 millimeter in the left main.
Yeah.
Yes,
Okay,
that's-
take
that's
22. There will be some foreshortening also, I think. Yeah.
Yes, sir.
How many of you will take pain of wiring these branches? There is nothing wrong in wiring, and there is nothing wrong in not wiring also in this
Sir,
case.
sir, I think it is a very large vessel. I think it is good to wire.
But large with a normal, almost normal ostium, so it cannot occlude. Hello. So
Yes,
I was
yes.
waiting for
The
you
ostium-
actually since 1 hour. Oh.
By IVAS ostium is almost normal, and
Still
that is why
ostium, there is a hedgy, there is mild plaque maybe.
OCT tells that ostium is healthy and wide area.
And the angle is favorable too.
Yes, angle is also reasonable.
So the proximal landing zone will be in the ostium of the LM or it will be in the shaft?
It is in the shaft.
It is in the shaft.
That's why I am taking 4 millimeter.
Yes. It is stent is 422, 23.
The LED is small, so I am taking 4 by 18.
Okay.
It's good enough, Sanjay. Just check it. Looks good, Sanjay.
Yes,
Little more in?
Little push.
No need, sir.
Okay.
Yeah, I think should be okay.
This looks good, Sanjay. Or little more?
Little more, huh?
Little bit more.
Yes, yes, looks okay.
Inject and see.
Looks okay.
Remember, you only have 8 millimeter balloon.
I like to pull back a bit.
Yeah.
Little bit.
You need to
Yes,
get
sir.
8 millimeter left.
Yes, we must have to keep 8 millimeter in the left main.
Okay.
I would check
Fine.
the overlap in the cranial view.
Should we go?
Okay, just take a cranial view. And we'll just do cine and see.
And the 8 millimeter thing in the left main is all just about whether or not you have enough room to pot. But really what you need is 8 millimeters from the proximal strut to the end of the point of confluence.
This looks good.
This is plenty big.
You're afford
Come to epicaudal now. Any change of mind?
Do we have any stent booster to have a look at that?
Stent
No,
boost,
this time
I
we
have
have
never
cross
used it
over.
actually.
This
looks
okay.
good. This looks good.
I
Go.
think it looks okay.
Go.
Go. No problem.
Low pressure.
10. Maybe 12.
No, I'm on 8. I'm on 8.
10.
9, 10.
Okay.
The flat.
Yeah,
A little bit. Yeah, we'll now come to the left main.
lot of restraint in the proximal LED.
Yeah.
You said the left main was a 4.0?
The left main is almost 4.5.
4.5.
Yeah, go.
Yes.
Yeah, but yeah.
Okay.
Go. I will pull it back. Go to 6.8.
When it starts
6.8.
to inflate. Yes, sir.
Go. 12. I think enough. Then we'll take another non-compliant balloon and go.
Yeah, if you're relatively certain that the edges of the stent are against the vessel wall, my typical practice in these situations is just to take the NC balloon. Because then you're controlling the proximal distal edges right down.
Yeah.
If you're not confident, then that's exactly
Oh no, no problem.
We can push balloon.
That's right.
Wire also. Okay.
Yes.
Okay.
And I
Wire is
inflating
secured
it
first
there
as for
to make
distal
it
and
fix. Oh, fine.
Okay.
Yes.
Deflate.
Go.
Yeah, and if you try to push it directly, sometimes, and you can give a good dissection at the left main ostium.
Yes.
It's pinch.
Okay, good. Pinch karta hai. What you see is the strut hanging there, and we will see on OCT. Let us do pot first, and then take a final OCT view, right, Dr. Akasaga? Pot with 4.5, I think. You can you give me the left main area? 12.86. The 5. 4. So 4.5 is a
4.5 is a little bit bigger. I'm
bigger.
afraid.
So we can go at a 4 and go at a very high pressure,
Yeah,
right?
right. Or 4.5 should be okay. If you
4.5 lead.
it depends.
5.
5.
So why not take a 5 balloon?
5 is a little bit bigger because
Bigger.
completely normal. So I'm afraid.
In my practice, in all honesty,
I think 4.5 is okay.
Yeah. You take a 5 balloon Sanjog for Canadian of Indian diaspora also, or the Canadian population.
Well, it's funny you should mention that. Toronto has a huge Indian population.
Yeah.
So a big part of my practice is actually South Asian patients.
4.5 by 8.
We image the hell out of everything. 4.5 by
6. Excellent. 6. 6 is perfect.
But I wouldn't be afraid to take that up to a real pressure.
Sir, in this case, if my landing
Have
zone
you
in the
update visual
ostium of
layout?
LM,
Okay.
is it give me more
Epicranial
freedom for expansion
Epicranial.
in the left main?
Yeah, it does.
This 4.5 or 6, what to 5, whatever it. If I cover the ostium, is it give me more freedom for expansion in the left main stem?
Looks.
Can you repeat the question?
Samir, do you see, Samir Tak and so, do you see that calcium getting stuck eccentrically on the wall?
Yes, we see that. And actually, it'll be interesting to see how the OCT looks in that area.
What's the
Go to
question for the
epicaudal.
left main stand?
In
Pardon?
In this scenario, if I put my stent in the left main ostium, and what is it give me more freedom for over expansion of the stent in the left main?
I think one should do optimal expansion rather than thinking of over expansion every time. Little in. Okay? Sanjay, this looks good.
Right, so
here we can go at 15.
I think the where he's going with that is that if you're not worried about dissecting the ostium, if you've landed
Yes,
right at the
that's
ostium,
right,
you can go to town, and that makes sense. I think in this case you have a totally normal central left main, so there's no specific indication to do that. But your point's well taken in that if you're going to bring it back to the os, it does take away a lot of the concern that you have with respect to balloon sizing.
80.
The question I have is when we talk about optimal expansion, we're talking based on the criteria of 90% of your distal MLA. But you don't really have that in the left main. You can't really use that criterion because you don't have the say, there is no distal MLA per se. So what do you define as optimal expansion?
Look at the origin of ramus now. Now, in OCT, if I see a good lumen and a little bit of hanging here and there and no much crowding, I will not even enter this ramus and leave it. Let us see. Any other idea you guys have in your mind?
I think the expansion of the very proximal LAD and that calcified area is what the OCT is going to answer for us very well.
So you have any doubt in mind?
A little bit right now. I want to see OCT giving me reassurance.
I have no doubt in my mind. OCT is going to give us reasonable, optimal, MSA everywhere throughout where the segment which we have stented. Let us see.
So on the panel, I work with one of my partners is Vlad Javik, who's fairly well known in bifurcation circles, and he it's interesting that operators seem to have their own biases. Does the panel have thoughts about systematic KBI after a crossover stent from the LAD to the left main? Does anybody systematically open the struts over the circ? Does anybody have a strong opinion not to? Just for the sake of discussion?
I will go case by case, depending on the case.
I think with one stent strategy, KBI is, even in the literature, is not really that beneficial. With two stent strategy, it's probably a necessity.
Right. So
yeah, I think pretty much the consensus. I think operator may be a special preference, but if you do routinely part for provisional standing, you really don't need final kissing inflation.
Yeah, I agree, yes. It depends on a case, but if we do the pod, we can identify the very good stent position and also the good condition of the orifice.
Ready?
Yeah. At that time, we don't need to do the
very
KBT, right?
But the part must be doing the right thing. The part must be before the bifurcation or at the bifurcation, not after.
Exactly. I think that's the key point, right, is that the pod has to be in the right place. And the other discussion is that 62% of plaque in the left main involves both branch vessels, right? It's the minority of plaque that only involves one.
Yeah.
So the argument becomes, is it safe to leave the other one, assuming there's no plaque?
Look at this.
Okay, right. From the distal to the proximal now, right? The position is very good and very circular. Yes, right. Very good.
Looks way better than even the angiogram looks.
Right. Lots of calcium behind the stent strut. Here is a very eccentric mixed blood, but opening is okay and the normal site is okay, right?
This is overlapping now.
Yeah, right. Here is an overlap. Yeah.
See, it looks much more circular than what I expected it to be.
Yeah, that's right.
And I think IVL makes that happen a lot.
You don't think Rota alone can do that?
No, it cannot do that. in this situation particularly?
Here is the left main. We cannot see the shaft not so well.
You want to take IVS run to see the ostium that we regularly do.
Or we can keep guide little out.
Yeah, but then injection will not be good, Sanjay.
Yes.
No. The guideliner, no. I think is it ready? This is okay, no problem.
Ostium पर रखो ना, ostium.
Chal, go to epicaudal. Go to epicaudal. Let me see.
Ostium ने cover करूँ तो नहीं आपने इतना.
जो तो scout.
Little back.
I am keeping it at the ostium now. Scout. Okay.
Still little.
Scout.
Still little back.
Scout.
I just.
Okay. Now take one view. Let me pull it back. Yeah. Let me pull it back. Now just see. Where is it?
Okay.
Now it will come now. Let us see the proximal part again.
Sure. Ready. Syringe drop.
No problem. No problem.
Vijay.
Wire. Where is the wire? It came out.
Everything
No problem. No problem.
Okay.
No problem. Do you see anything?
Syringe drop.
It's okay. It's okay. Now let me take the final views then. Samir?
Yes.
You wanted to see the 360-degree subclavian loop. Let me first inject and check this. Go to AP.
Blunt tip of wire.
Get me a blunt tip of the wire. So it must be a long flight. Yeah. Wasn't bad. Yeah. I know. So you are converting adversity into fun. Yeah. Yeah. See? Okay? Come. Okay, fine. Go to areocranial and epicaudal. Dr. Akasaka, can you show that bifurcation?
Okay.
And ramus origin on OCT. By the time we'll finish this. Looks perfect, huh? Go to areocaudal. What do you think?
It looks amazing. It's almost a type 4 LAD.
Look at this. And I am sure that bifurcation will not show much of the things, a bit of strut hanging here and there.
Looks very good.
આમાં આવી જાય ને એ તો આવી જ ગયું છે ને સંજય.
ના સિરીઝ તૂટી ગઈ ને આપણે.
નહીં પણ લેફ્ટ મેઇન તમારું એ એરિયા આવી નથી ગયો.
લગભગ નથી આવ્યો.
I think bifurcation, you have not got the bifurcation there?
Syringe drop before.
The first view.
First view માં તો આવી ગયું.
First view. You have the bifurcation there, right?
Right, yes. First view, right?
No, after stenting.
After stenting. Right.
Yes.
Okay.
Yeah, we want to apply bifurcation, yeah. That is a small circumflex origin, what we see there.
Here is circumflex origin, right? Right? No. Here is this is a circumflex, I think. Yes.
That is a big one, the ramus one.
Yeah.
Sometimes it is seen well in a fly-through,
Fly-through, you want?
Yeah.
Where is the fly-through? Right. This one, yes. Right. Okay, right.
Not seen. Not seen.
By the wire position, right?
So what is the opinion of the audience? Are we doing again to see the bifurcation, or is all right and we shift to zero contrast IVS case next, left main ostium, last case of the day?
I think this is fine.
This is fine.
Yes, absolutely.
Yeah, that's fine. That's fine. Okay, then we are done.
So
Fine.
loop.
Loop. Let us say the yeah.
loop
Just show
बता
AP up. AP
ऊपर
में जा
loop
ऊपर बताए.
नीचे
ऊपर बताए.
ऊपर ट्यूब नीचे लाए.
ट्यूब नीचे ले. Okay.
चलो.
You saw that 360 degree at one angle. Want to compare it with the previous angiogram is